afternoon, everyone, and welcome to the Communicating with Confianza, a Health Literacy Eco Series. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the Eco session today. This session is brought to you by Health Confianza team in collaboration with the UT Health San Antonio Super Hub, the YMCA, South Central EHEC, and the University of Texas at Austin. Please, let me start by saying that Health Confianza is a community-wide health literacy program that aims to provide health literacy education, training, resources, workforce development for Bejar County and the surrounding areas. Confianza is the Spanish word for trust. We discussed that last time that we have a meeting. Our team believes that health literacy is critical to transform health and to achieve health equity for all. With the goal of increased health literacy in our communities, these sessions were carefully planned to equip with tools and skills to all those attend the session. So everyone is welcome to join our session, but it's very important that each session build upon each other. We may have a different reasons to join this session, but there is one consistent thing that I believe bring us closer together, and is the desire to have a deep understanding of the health literacy. So thank you so much for your support and the trust in us. I invite you to explore what we have to offer in the following sessions. So I invite you to put in your calendar and join our sessions in the following time. For those that are new to the ECHO platform, ECHO stands for Extension for Community Health Outcomes, a virtual telementoring, especially designed to create a connection between communities and subject matter experts. The ECHO session has the following core elements. We begin with welcome, then we do the introductions and announcements, and then we have a brief didactic, then a case presentation and a group discussion. So if you are interested in submitting a real life story, please contact the Administration ECHO team for more information. And please remember that no personal health information, the PHI, is allowed to share at any point of the session. So what is personal health information? DOB, date of birth, addresses, appointment dates, etc. Now, before we go to the introductions to the Health Confianza team, there are a few technical points that I would like to mention. Help us with our attendance records. Please enter your name, your full name, affiliation, and email address in the chat box. Please stay muted, only you are speaking, but we promote interaction in our session, so we invite you and encourage you to join us by video, particularly, especially in the discussion part of the session. If you have any connection issue, please send a message to the ECHO IT for assistance. So now I would like to move to the introductions. Let me start by mentioning Dr. Stone. Would you please introduce yourself?
Yes, good afternoon, everyone. Glad to see many faces returning from our first ECHO session. I am Dr. Melanie Stone, an assistant director here at the UT San Antonio Department of Family and Community Medicine, and I direct our Community Engaged Learning program at the university, and I serve as the co-director of Health Confianza, along with Dr. Jason Rosenfeld. Thanks.
Dr. Rosenfeld?
He's coming.
Okay. I'm sorry.
You guys hear me? All right, this is Jason Rosenfeld, UT Health San Antonio, co-director of Health 25 Community.
Thank you very much. Thank you. I believe that. Thank you so much for joining our session. I see Corinne Reyes, lead specialist for the session today.
Hi, good afternoon, everybody. Corinne Reyes. I'm a registered nurse. I'm the Chief Programming Officer for YWCA San Antonio, and we are former graduates of the Health Confianza Pledge Program.
Yes, thank you so much for joining our session today. We have Guadalupe Cornejo, didactics presenter.
Yes, good morning, everyone. I'm Guadalupe Cornejo. I'm joining from Northwest Vista College. I'm a faculty member and program coordinator. Thank you for the opportunity.
Well, thank you so much for being with us. And Raudel Bobadilla is a case presenter today.
Hello, everyone. My name is Raudel Bobadilla. I'm a program manager at CHW Way for the stop. HCCHCB program here in South Texas. Thank you.
Thank you very much. And I will move to announcements. I have some updates and announcements. Please join the YMCA San Antonio for the Community Connections Resource Fair. Come to connect with local partners, explore resources for health, education, childcare, and more, all in one place. Please join us in that. Thank you so much for bringing that opportunity. And as a quick reminder, towards the end of the session, our team will send you a link for the CMEs and evaluation of our session. This session are possible because of you. Thank you so much for joining, and please provide the feedback. It's so important for us. So finally, I would like to mention that ECHO is all teach, all learn environment. So we encourage you to share your experience, questions, and insights for the session, and use just chat or the camera if you feel more confident. So with no more comment, and I would like to move to the didactics. So Guadalupe Cornejo is in charge of the didactics today. When you're ready.
Thank you, Dr. Romero. I'm going to try to share my screen if my technology doesn't fail me. Okay, am I sharing the right thing?
That looks great.
Okay, thanks.
Thank you.
Thanks, everyone. Thank you. It is truly an honor to share this learning space and community with you all. Thank you, Dr. Rosenfeld and the team for the invitation and this opportunity. Today, I will be talking about, my title is the CHW Way. But then when Dr. Rosenfeld invited me, and I'm, full disclosure, I'm really not creative when it comes to titles, but since I want to be talking about CHW work and field and who we are and our areas of competency, I always have this say of the CHW way. So I hope it resonates. But when I think about the CHW way, I think about how we as community health workers, when I'm having students in the classroom for the very first time, I ask them, the reason why they choose to be in this field. And I'm not surprised to anyone. Many of us, including myself, talk about how our experiences that we had, perhaps navigating systems for ourselves or families or friends, created a sense of awareness of the challenges that exist navigating difficult systems such as healthcare, social services, or education. So when I say the CHW way, that's some of the things that I think about, that is that we operate through our experience. Many of us truly have been through some traumatic or difficult experiences, and we are now turning those challenges and wisdom into something that is fulfilling and allows us to work with other people in these spaces. So truly just focusing a lot on the base approach, asset-based approach is how I think when I think the CHW way. When I think about the CHW way, I also think about have to adapt to the circumstances. Not everything goes as planned, and especially in settings in where we have to adapt to the circumstances. And what comes to mind is when we are out in the community or out doing a home visit and things don't go as planned. So we have to adapt and do it the CHW way. So for today, my learning objectives are defining the scope of practice of the CHW. I figure that perhaps there will be more than one person today that perhaps still doesn't understand what CHWs do. How can I incorporate CHWs into my practice? How can I truly allow opportunities for that CHW team member to flourish and provide the best that they have to offer to my program, my department, or my organization? So I'm going to start by defining the CHW scope of practice, and also talking about how our identities as CHWs are shaped by our experiences, which allow us to have a unique perspective, and also how those influence our way that we conduct our work or our field of practice. And then I use an example to show this approach. I no longer provide direct care or patient navigation, but I do have this perspective of the work that I do with my students and the work that I do in community and with different collaborators. So to begin, the CHW scope of practice, you all must know that we are non-clinical. So we are your non-medical drivers of health workers. So CHWs are indeed part of the frontline public health workforce. And we, by textbook definition or American public health definition, we are trusted members of the community that they serve. And we are trusted members. It doesn't always mean that we are part of that community, that we live in that community, or that we identify as such for specific or different community groups. But we do have a genuine understanding and ability to understand what those community members may be experiencing, either because we have other connections with them. So not necessarily limited to geographical or identity. The scope of practice, like I said, is non-clinical. We serve as liaisons. We are navigators. We help be that bridge or connection between different systems, such as the healthcare system, social, educational, and even some private systems. And our work is to navigate those systems and provide that connection to the community so that our community members or patients or clients can access those services and improve the quality and cultural competence of service delivery. And I would say consumption, right? If you see it from the perspective of the patient or consumer, a lot of times people don't, and we see it in perhaps in low attendance or low numbers in many of the programs that we offer to the community. But and we wonder why they're not accessing the services, whether the services are free or that they can truly provide a benefit for them. But if we don't do it from a respectful cultural perspective and competence, then we can have those poor results of connecting both the community to the program or organization. So yes, we are non-clinical. We are based on, our approaches are based on advocacy, health promotion, education, navigation. And we indeed are those trusted social drivers of health or social determinants of health, whatever term you feel comfortable using. So our workforce, our community health worker workforce is very diverse, not only in the sense of ethnicity, but in the sense of preparation. We have in our profile for San Antonio, we have the majority of our community health workers are with some college, some are with a certificate or associate's degree, but we also have we're increasingly seeing a number of individuals with bachelor's and master's that are acquiring their certification. We also have community health workers that get certified by experience, and we also have CHWs that are not certified. And with that being said, is that there is then a diverse way of how CHWs do their work, and also some of the expectations that perhaps employers may have. But all of us who are certified by the state of Texas, we are certified based on these 8 competencies, and of course soon to be 9. But what this means is that even though we are in this field because we have a passion to help people, or because we went through similar situations, our training does prepare us to see beyond just the emotion or the emotion. I'm going to stay there. I was going to say compassion, but compassion is truly what drives our work. But what I'm saying here is that we are trained in these different competencies. And that's something that anyone who is not still incorporating CHWs, I hope that you have a better understanding after today of all the different ways that the CHW can be utilized. And so with that being said, I'm also now talking to our CHWs in this meeting, in this call. We do our work, like I said, shaped by the different lived experiences and identities that we carry. We do, I think we're very good at code switching, right? And those identities and experiences are really valuable in ways of helping us to connect with the populations that we are serving. And a lot of times when I see CHWs that perhaps, their certification is the first higher education experience that they have, they may sometimes see like, well, I don't have much to offer, especially when I see them for the first time in my classroom. But once I start having this conversation of helping us to do an inventory of what we bring to the table, I use that as a tool to really highlight that your lived experiences are providing us with wisdom. And so I offer this perspective of, to ask the CHW to have this reflection on their social connections that they have and that they bring to the organizations, their social capital, right? Defined as positive connections. So your personal, as the CHW is completing a personal profile, looking at the lived experiences, plus adding, additional training and education they're receiving, and then looking at how all the different connections that they have that perhaps for organizations may not already have access, right? When you start asking like, what are your connections in your community? And you start finding that they truly know how to connect with the faith group community, that they know that they have, that they're very active with their home associations or parents groups or any other groups. Those are places that not everyone have access to. And that for all of us that do education or public health work, those are the places and the people that we are trying to reach. And that a lot of times we don't reach just based on a social media post or a presentation in our organizations. We truly need those connections and networks that the community health worker brings to the organization. Then also the way that that increases the value, right, with their professional setting and their professional practice, who they associate with who they represent, and furthermore, outside of the professional role, the professional affiliations that they have and the contributions and connections that allows them, thus increasing the value of their social capital and how they can, and the connections that they bring back to the organization. So I will try to share here my example of the inventory of identities and lived experiences and how those help me view the world, and also the levels of influence that each of these connections have provided me and shape my personal practice as a community health worker. So my background, different identities. I always say that being brown and female sometimes can bring challenges. Like I grew up in Mexico, and I grew up experiencing some sort of discrimination just based on the color of my skin, right? Growing up, feeling like the patito feo de la familia because you're brown, and everyone in your family thinks that la güerita is, la más bonita, and how that at an early age starts shaping who you are and and how you see that others see you or don't see you just based on your identity. I'm an immigrant from Mexico, and that tells you a lot about, how I may see the world, how certain changes in politics and policies may affect the way I see myself and the way that I see others. I do have dual citizenship. And when I moved to this country, I landed in District 5. And as we know, those are the districts, District 5 is one of the districts that show up in a lot of the reports that you see that have the lowest everything, the lowest education attainment, the highest, poverty rate, or why not. And that also, as I'm growing in my profession and my practice, allows me to develop a way of how I shape my activities and my work, knowing where I come from. I'm a community health worker instructor. I'm a licensed master social worker, but I always say that it's very difficult for me to remove myself from my identity of CHW, so I typically usually present myself or introduce myself as a CHW. I'm assistant professor of community health, where I have the opportunity to see individuals who from different backgrounds and with different aspirations and passions of life. And that is truly a privilege for me. I'm a caregiver. I'm a caregiver of a mother with Alzheimer's. I'm a caregiver of someone. I'm a sister with breast cancer. I'm an advocate for my community. I'm a mentor for my students. And I'm a sister and I'm an aunt. And on the other side here, you see the community engagement background. And I see those as spaces of influence. I see those as spaces of opportunity and opportunities for me to bring the voice of people that may feel that they don't have a voice right now, people that are too busy to provide the feedback so that we as individuals in charge of developing programming can truly understand what their needs are. So all these connections that I have as community engagement, I do it for not only thinking about my personal professional growth, but also always thinking that what I can share from my lived experiences can hopefully make a difference on how programs and procedures are shaped so that they can truly reach the populations or communities that I care about. One way that I like to show this on the CHW Way in action is that kind of using a recent experience I had with someone that was experiencing a health issue. She knew that she had high blood pressure. And these were the circumstances for this individual, immigrant, female, only speaks Spanish, discloses to me that she does not have insurance, health insurance, and is currently grieving the loss of a loved one. And as she's talking to me, right, it's one of those ways that we connect with people as a CHW. You don't have to be my patient. You don't have to fill out this long intake form for me to develop that connection and rapport with you. But all this information she's disclosing to me is just because we have been seeing each other, running into each other at work, and always saying, how are you, or where have you been? And that simple question of where have you been, I haven't seen you, is what allowed her and allowed us to have this conversation, where I found out that she does not have insurance, that she was absent from work because she ran out of medication, and she was she was not feeling well to come to work, right? And even though she's employed. And so I do have that reference. The chart here is just for a reference, right? To know what what is high blood pressure, or what are the considered abnormal or abnormal high blood pressure or elevated high blood pressure. But for me, just to knowing that, is being able to listen, and as she's describing all the things that are happening to her, and for me, having a lot of similarities of understanding as an immigrant, as a female, no insurance, grieving the loss of someone, of a daughter. I can only imagine, how she feels helpless, to the point that we know that there are plenty of resources that she could be accessing, but grieving the loss of a loved one is beyond, it's putting you in that tunnel vision where you cannot really find the answers, even if the answers are in front of you. So for me, one practical way that I use to assess or appraise any situations that I come across, I use these two models, right, that allow me to identify barriers, and not just barriers, but also helps me identify the potential support systems for my patient or my client. And so I start by using these two approaches, but in practical ways, not in very theoretical, complex ways. So for me, my coworker is sharing those things with me, I start assessing, all right, well, what is her knowledge? She knows that she does understand the signs and symptoms of depression, of high blood pressure. She tells me that she doesn't feel well. She tells me that she doesn't have when I look at the interpersonal level, she tells me that she doesn't feel supported. She's an immigrant. So as an immigrant, I know that a lot of times our social support systems may or may not exist, right? I've started looking at, all right, what organizations I know that can help me with this situation, that I can connect this person with those resources that she needs. And then look at the community level too, and the policy level. All right, can she apply at this point for health insurance? Is the marketplace open? And then I look at the dimensions of wellness. And these are tools that we can use beyond just the practical intake forms that your organization may offer, but truly just how using these two approaches will help understand and identify those areas of need that may a lot of times we don't capture in those forms. The dimensions of wellness is truly a framework that I love using in the sense that I know that I start kind of assessing or appraising each one of those. I know that her physical health is not at the greatest right now, and you can see the signs, right? As I'm looking at my coworker, that she looks tired, that she looks disconnected, that she doesn't look well, and then I start assessing, what areas are being affected. Her occupational dimension is being affected. She's missing work, which means that she will then eventually have financial issues, right? Her emotional dimension was being impacted by the loss of a loved one. I cannot, at that point, offer any resources for the intellectual dimension, because I know that I will not give her a lecture of, what is high blood pressure, or go read about these resources, right? At this point, I'm making the decision that the help or assistance that I can offer, or support I can offer, is in a practical way, and is assessing is looking at, asking the person, what kind of help or support I can offer you. And so I start by, the trust is already established. She trusts me to the point that she disclosed all that information. And I felt comfortable in asking at that point, do you need help? Or you're only sharing with me, right? And after I make all those appraisals using those two models, the socioecological model and the dimensions of wellness, then I decide, which resources I know that I trust, especially in this political environment, that I can send someone where I feel like they will be respected and that she will get the help without those other additional questions that can help lead the patient to have fear or distrust to the system. So what I did in this situation is that I provided information, I provided phone numbers, I navigated the individual to actually obtain the appointment. And this is where a lot of times I think that as CHWs, we may have some pushback sometimes from our supervisors in the sense that we know that we want to lead the patients to be self-sufficient, but I think that you have to truly assess where the person is at that point. Can they do that on their own? Or this is the time where you as the navigator, as a CHW, have to lead the way by making that phone call, by getting that appointment for them, by making that connection. And then following up to ensure that that individual indeed access the services that they needed. I'll stop here for discussions or any questions or reactions. But I finish by saying that when I talk about the CHW way, is all the things that I share, is that a lot of times we as organizations have systems and forms and processes that I can only imagine someone who's in true need of service, to say, all right, well, call me in 2 days and I schedule your appointment for an intake. The person comes, does the intake. All right, now I'm going to schedule another appointment so that we can actually, help you with what you need. And so it's something that I'm truly proud of us, of the work that CHW do, is that we are ready to help and we are ready to work with the individual and provide the support that they need when they need it the most. And I think that is one of the benefits that we have in our profession, that we, compared to other professions that have very strict code of ethics or very strict limitations on how they practice their work, that we can truly be embedded in community and have those connections. And a lot of times, most of the significant work that we do is truly outside of those working hours, the 8 to 5. And that's another thing that I think is very unique of the CHW way, is that it's, you're always there in community, and the community knows that they can come to you on a Sunday, on a Saturday. I do teach about professional boundaries. I do teach about taking care of yourself, but I also applaud the fact that we can be there for the community when they need us the most. Thank you.
Thank you very much. Well, there was a very nice presentation, and really like when you were referring to inventory of identity and the living experience, because that brings your own experience, the knowledge, the wisdom you mentioned as a component, as a skill for the community, for workers. And thank you for sharing your story with us. Thank you very much. We all have a story to share. Thank you so much for your story. We hear that. Is there any question?
There's a couple of questions in the chat, Dr. Romero.
Okay, let me go through the chat.
Yeah.
Okay, question. As a member of SAISD, Health Counselor member, what is your view on the form that parents today have to sign for the students? A little bit. To their students to receive or not receive healthcare assistance from the school healthcare worker or nurse. What is the new policy based on?
That's an excellent question, Sandra. And I have not discussed that with the council, so I don't have an answer for you. I'm sorry, but
Yeah. I mean, that policy is state-based. It's not based on anything within the district. I could give you a very political answer about why I think that form has been put in place. But you guys as parents and teachers, etc., I would just say, encourage your parents to just go ahead and sign that form by building that trusting relationship with them. There shouldn't be a problem with them signing that form, and don't let it be a form of division that they're going to win this battle.
thanks, Corinne. I appreciate that. And just to add to that is that parents should be involved in these committees. I don't have children, and the reason I'm involved in the committee is because there is really no one that looks like us, you know. When I joined representing District 5 and Lanier, right? But there's only a few parents that attend this meeting, and this is where I always call everyone to be involved in advocacy, because this is where even though this is a state policy, at this level, every district also has, to some extent, some power to change things where possible that truly align with the needs of of that specific school or district. And they can only be informed by parents being involved and by advocates like ourselves.
Thank you very much. And actually, here I have another question. As a social worker, what strengths do you see in the community health worker certification that are not present in a LMSW license? That was from.
Well, that's a very good question. You know, a master and licensed social work it's different, it's elevated. I think our CHW, at least our CHW program at Northwest Vista, combines both approaches of social work and public health. But what I can tell you is that, like I tell everyone, is the connections, is the community level connections to resources and to people that in a master's or bachelor's program, you don't find as engaging. At least that was not my personal experience. So, I mean, I have students that are, that have other degrees, and they find valuable the certification process just because of those connections that you have, like direct connections to community resources and people.
Thank you. And we're from we want to read all things. Thank you for the chat. We want to read all the chats. It's very important to share all these questions. Just one more, and then we want to move to our next part of the ECHO, which is the case presentation. So what is the difference between community health worker and health navigator?
The community health worker is an umbrella term. So I would say community health worker, that was my training. That was my higher education path. So once I graduated, I worked as a patient navigator. So in many ways, being a community health worker is that umbrella term, and then you can be a patient advocate. You can be anything really. That I always say, my students, read the job description. And if that aligns with the CHW competencies and your passion as far as the population and communities that you are compelled to serve, then that's your job. Forget about the title, right? It's truly the competencies and the passion that you have and what you want to give for that community and what you want to learn.
Thank you, Guadalupe. Briefly, Sandra Sanchez says, I'm a patient navigator and a community health worker. What helps me is that I work in a healthcare settings already. So it's just an addition what you just mentioned. But please keep sharing your ideas and your thoughts. We promise to read all this in the chat, but if that's okay to you, we want to move to another part of the ECHO, which is the case presentation. And we have Radel Bobadilla, who's going to present the case.
Thank you, Dr. Merrill. So I just want to bring up, again, my name is Guadalupe. I work with UT Health San Antonio. I currently work with STOP HCHCV program, which provides hepatitis C treatment and management to uninsured individuals in rural South Texas. This program has been running for the last 3 or 4 years. So I'm going to discuss a scenario that came up. And I'm wondering if y'all could provide me just things that I could have done better as a case manager. I'm also CHWI too, so we're well connected to my community and just would like to hear perspectives from everyone. So we had a newly diagnosed HIV patient from one of our rural clinical sites that came in for educational and lab work to start initiating treatment. With this, labs are usually is your labs to recommend treatment, and then we do an ultrasound as well. An ultrasound is very important just to see what's going on with your liver, be able to make a recommendation, make sure there's no mass or anything else we should be worried about before putting a patient on treatment. So we did that with her. We let her know. We offered initial education, then she did her labs, and we sent her off for her ultrasound. About a week later, she came back because we had all the results. But she seemed visibly emotional and distressed at this visit. And I think after that initial visit and the ultrasound, I feel like we didn't explain it correctly as we should have had. So she was significantly stressed out because she thought that because she got an ultrasound that meant that her liver was completely damaged and she was going to need, she kind of spiraled. I'm going to need a liver transplant. How bad is it? Like, could I even get on treatment at this point? Because so what I picked up was because she got an ultrasound, she immediately thought that her liver was shot and she's going to need a new liver. When in reality, it was just procedure to and protocol to get lab work and an ultrasound done at that point. So she was like, "Do I need a transplant? Like, what are my plans? What do we need to do?" And at that point, I really had to like calm her down and let her know. I was like, no, this was just procedure. So I just let her know that that was not the case. Ultrasound was routine labs for every one of our patients going through Hep C treatment. And at that point, I provided some education on our processes for getting patients onto treatment. But I felt incredibly bad because I'm like, I gave someone stress and they were spiraling because maybe I didn't explain things correctly and I didn't. Explain the processes correctly. So she felt relief once I let her know that this was routine. But that just let me know that I need to give out more information on getting HCV treatments and providing a step-by-step process to these newly diagnosed patients can really affect their care and how they interact with us and how they trust us as well too. So um, that was what went well. What could have went well. What went well is that she eventually understood that this was just procedure at all, but I could have explained it better, I think, initially when we came in for labs. The next slide, just want to be so my questions for our learnings group today is what health literacy strategies could I have used to inform newly diagnosed HCV patients about the important information regarding their diagnosis? And then all the follow-ups of the process of getting onto treatment and the situation that I highlighted. Did I have another question? That was it. Okay, yeah. So just health literacy strategies around that and what I could have done better and how could I prevent this from happening to the future? Just because there is a lot of steps. It is a brand new diagnosis for a lot of people that had no idea, so they're in shock initially. Yeah, any suggestions would be appreciated about strategies. Thank you.
I'm speaking for within this room that I'm in on behalf of Miguel Padilla with Patriot Home Health. He wanted me to acknowledge that Teach Back would have been a good tool to utilize in this. Yeah.
Thank you very much. So what the strategy we can use to inform the person about the test, but also about the diagnosis, right? So, and then what is coming, like Gabriel says, so teaching back. It's another comment, suggestion, Dr. Stone?
Yeah, I do have a few thoughts, but let me just see if anybody, I don't want to, here, Amanda, I don't want to take over. So Amanda, you go ahead first.
Oh, no, you're fine, but thank you. So I would, along with what Miguel had said, but also asking them if they understand the function of the organ initially. Because even I had a discussion with somebody recently, and they had mentioned how they've had chronic anemia, And now they're having heart issues and they need to see a cardiologist, and they didn't understand the connection. And so even in that conversation with them, even though they had already seen their doctor, I was able to help them understand that how low iron and the lack of oxygen can also affect your heart, and that was a connection. So also asking the individual if they understand the normal function of that organ, and then the connection between the diagnosis and the functionality would be helpful.
Yeah.
Yeah. Yeah, thanks so much, Amanda, about that. Yeah, and we have a mobile app that educates people on their diagnosis, what it means, and how to prevent, but it doesn't go into the processes either. I think that was our shortfall too. We just hand them usually the tablet for them to go through it on their own, when in reality, just because our MAs or sometimes ourselves, we're just running around the clinic. So it's hard to really stop and just sit there with them, because we don't know if they're capturing everything or not, even though the app does offer like teach back questions as they're going through the app. We're not sure if they're actually understanding or just pressing whatever. So I think that puts in perspective. It really put in perspective for me. It's like, oh no, maybe I need to sit down with some folks and just walk it through and then ask teach back questions. Yeah, completely agree.
And actually,
Mhm.
this is a very good point. And in fact, Rosalia, you say that you come across to similar situations. You want to mention? You want to elaborate a little bit more on this? I saw that in the chat. Well, Rosalia, not sure if she can unmute herself. Okay, so let me read what is in the chat. I come across a similar situation, like create a short video explaining treatment.
Right. So what happened to me was that we were trying to educate the patient on a better lifestyle, right? Just in regards to nutrition. And
Oh.
what I found out was that they weren't giving me pushback, but they just weren't understanding the process. And I was like, you know what? Let me just create a little short video. It was less than 3 minutes. It hit all the points. And I was like, after the video, I was like, can you repeat what you heard?
Mm-hmm.
And they said yes. And then that gave us a better conversation. I understood what he was understanding and what he didn't understand. And so that just helped us understand his health issues better. He left in a better educated, in other words. And then I was able to connect him to a Western nurse in that area. And he was from a rural area. The Western nurses are free. And before he left, I was able to have both of them talk. And they even set up an appointment. Western nurse was able to check his sugars, blood pressure, and help him with any follow-up assistance or medical equipment. And I think it became a good outcome for him because he was able to control his sugars. He had a lot of problems with boils. And so as he started eating better and trying to stay fit, he didn't have to come back into the emergency room. Now we were just able to connect him to someone where he could do his follow-up appointments. And so I tracked his progress for 6 months, which came out to be a positive experience.
Very good.
No, that's great, Rosalie. I think we're also in rural communities and also have Wesley nurses, but I've never thought to involve them in this aspect. So it might be good to connect them as an extra resource as well within our patients too. So yeah, thank you so much for sharing that.
Yeah, and Dr. Rosenthal says, I love it. Tapping into the community care worker way, the Wesley nurses are amazing community resources. Thank you for bringing that. All those medical terms are not easy, and understand the physiology and then the physiopathology and then the chronic condition, all those terms, when you receive a new diagnosis, is like, no more, right? You don't hear anything more. It's just a silent. It's so much information. So having someone who can hear and can listen this is very, very important. Daisy, Rita, you wanna verbalize? You wanna elaborate a little bit on your comment? Talking about the overwhelming when a new diagnosis, right? When a person receives a new diagnosis, is like,
Basically, I'm not giving a suggestion, just reiterating, that it is shocking for people when they get a diagnosis diagnosis, and you may not even hear the following words. And as I said there, ideally you should be accompanied by a family member or somebody that you trust. No, even a community health worker, not like we do in our team. We try to offer that to patients. So that they have extra support, extra ears. No, doesn't always work. No, but if you, let's say, if it's a family member, they may be in shock as well. But if it's a community health worker that they trust, no, they may be able to come up with additional questions or request clarification of the information when you see that the person may be confused or distracted at the moment. No, so that's why I wrote that. No, and right there asking the person, can you do you have any questions? What do you understand about this or that? No, or the treatment, the options, and reassuring them. When we request for additional testing, it doesn't mean no, that is because we're expecting to find something abnormal, no, but it's part of the procedure, no, we want to make sure, no, so just a lot of reassurance and comforting words, not to lie, no, but to reassure them, no, it's not that the worst is being expected at this moment. So thank you.
Yeah, no.
Yeah.
Thank you, Daisy. Yeah, this was definitely a wake-up call for us because for us, it's just procedure. It's just another patient we're trying to get on treatment when in reality, it is very life-shocking and it is a big deal for a lot of people, even though for us, it's a day-to-day as we're treating others. So, no, yeah, completely agree. Thanks so much, Daisy, for including that. And I think that for this patient, I've really, really tried to find ways in which I could better explain the process and be more of a advocate and a person that they could trust through their diagnosis and treatment, other than just another patient that I have to put on treatment because that's the best thing for them. Mhm.
Each person, each patient is each patient. Everyone has a different needs, and just a diagnosis plus treatment. All these strategies are very important, particularly because it's communication and it's empathy involved with really reinforced. There is another comment here. Excellent visual aids are great to learn and understand diagnosis. And then Pat Sanchez, I think it's a good idea to have someone there during the appointment because, like Rita says, it's another ears, another eyes, and it's so much information in one point. I think the question from the staff from the doctor office should be asking to the patients if there is someone them. Yeah, that is a very, very good idea. Now, Dr. Stone, you wanna continue?
Wonderful. I love all of the health literacy practices that have been mentioned. Teach back. We're going to have a whole session on teach back a little bit later in the series. Having someone with you during an appointment to help understand and ask questions that you as the patient may not think about, and also to talk about with later. I just wanted to say, Rodell, I feel like you're giving yourself a hard time. I think this is a very common situation, unfortunately, in healthcare. The fact that you recognized it and that you and your team are going to make some changes is what's important. And this really illustrates the issue of organizational health literacy. You're part of a system that maybe needs, to kind of look at its policies and practices so that they can overall make sure that as people go through their process, they're getting the communication and the information that they need. So as people have said, when you get a new diagnosis of that magnitude, you're going to have your health literacy may shift. Even if you normally have pretty high health literacy, it's going to likely decrease in that moment because of the shock and the fear. And so you're going to build that relationship with this patient over time. And you want to make sure your system is going to have good communication, good forms, encouraging questions, making sure all of your team members have a role in making sure that that person will be able to feel comfortable in speaking up, saying what their concerns are. And then, of course, using Teachback to assess understanding, at key points along the way. So I applaud you for sharing this with our group here today and letting us all think about what can our organizations do to help make the system better and easier for that patient so they feel more comfortable.
Yeah, and elaborating a little bit more in this and adding actually for the comment before, like a family member be at the time of the visit. There is a Jennifer that says you can at least have someone on the speaker on your cell phone. I did this with my brother when he was going through a cancer treatment. He wanted to stay away. So that's another option. So we can always try to see what else we can do to help us and to help others in these regards, because having a new diagnosis or a new test has to be done is overwhelming for everybody. What is another Dr. Rosenfeld? And it's about acknowledging each individual's perspective as a viewpoint on out rather the word can become routine for a provider. True, right? Because it is kind of like normal and it's a routine. But for each person, is each situation, right? Is individual. So community care workers and other health workers, but if we must find a way to acknowledge each individual on their perspectives and the lived experience as if for the first time. Yes, it's very, very important. Now, there is a question, how do we get a link for the CEUs that was already offered to you? Is another comment. I think I will read all this message in the chat. Is another comment, another thought, another story that you want to share in a few more minutes?
I think all the rest of the comments are mostly about the CEUs. I think you got them all, Dr. Romero. And just like touching back to what Dr. Rosenfeld said, I was just curious, particularly for Guadalupe, you're both a social worker and a community health worker. How do you personally, like working as a community health worker, acknowledge perspectives when you're talking within the community? And how do you feel that's different than as you do it as a social worker? I'd say that because as a nurse and a community health worker, I feel like they're two different skill sets for sure. And I'm curious about your perspective on that.
Yeah, that's a good and challenging question. I think most definitely my CHW perspective is always very practical, whereas my social worker perspective, I'm looking at policy, I'm looking at macro level impact. And I'm always operating in the practical aspect of things. So I usually rely on my CHW perspective for most things. Like from my CHW perspective, just like providing that practical guidance, support, connection, phone number. Whereas in my social work aspect is like, all right, what can I do here to change? Like, for instance, in this situation, everyone needs a patient navigator. Everyone needs a CHW. Like the clinical team is doing their clinical work. The compassionate care, the follow-up should be done by CHW. And a lot of times outside of the clinical setting, we're like, oh, let me give you a call, or do you want a home visit? And a couple of days after the diagnosis, which is when people are already kind of out of shock and thinking about the implications of a new diagnosis in their life. Am I gonna need treatment? Do I have health insurance? I'm gonna lose my job, or I lost my job, now what? So yeah, so I guess CHW always think of it practical, social worker a little bit more complex. But most of my experience is in the CHW. I always wear my CHW hat on. That's probably the one that I use the most.
Thank you very much, Guadalupe. Dr. Stone, you have a very important also comment in the chat. Do you want to elaborate a little bit more in the last minute that we have?
I was filling in just what we had been saying about navigating the difficulty of some of these health conditions. But I had a question for current for Guadalupe. I don't know. I think Corinne was talking when I wrote it. Guadalupe, do you feel like CHWs, they're wonderful health literacy conduits, but they don't necessarily get formal training in health literacy. Do you feel like there is a need for more formalized training of some of these skills that we've been talking about in this series?
Oh, that's always a yes. Yes. I mean, and especially because, for some, they may be, you get used to the practice of what's required of you. And a lot of them may not always be working in spaces where they can use health literacy skills. They're more practical in other ways. So yes, it definitely, I mean, health literacy is a continuing education process, a lifelong process for all of us.
Well, thank you so much because I really like this one, kind of for closing, continuing education because more sessions are coming and we invite you to come to that session. But before, real quickly, Corinne, do you have any comment for the recommendations as a lead specialist for this session today?
I think we got it all out there. So it was a good session. So I really appreciate everybody.
Well, thank you so much. Yes, I'm going to use it as a connection then, just to please join us in our following session. So thank you so much for the session today. Thank you for the wonderful didactics and presentation. That was a very excellent discussion. Please join us in October. Can you believe that October 2nd is already coming? So to learn about the credits, the information is in the chat. And for those that are claiming for the community health worker certificates, this is gonna be open until Wednesday, 9/24, so next week. So we're looking for see you next week. Until then, please take care and mark your calendars for next time. Thank you so much.